Okay? That would be negligent if to not allow physicians to prescribe off-label. That would be crazy. Often the gold standard treatment is the off-label treatment. That would be a crazy proposal. Okay? Well, let's think about that for a moment. Off-label prescriptions have not been efficacy tested. They have not been through FDA-required efficacy trials, okay, in the off-label use. They may have been tried, in scientific and peer-reviewed literature by universities and so forth, but they have not gone through FDA efficacy-approved trials. Okay? So off-label prescribing is really very much like prescribing a new drug that has been safety tested but not efficacy tested. Okay? An off-label drug has not been through FDA-required efficacy trials, like quinacrine for BJD. It has not been approved. Quinacrine has not been approved for the treatment of BJD. Okay? So off-label prescribing is very much like prescribing a new drug, which has been through some trials, but not that many, perhaps. Okay? Well, since there are many benefits to off-label prescribing, and physicians are strongly in favor of off-label prescribing, this suggests to me that allowing physicians to prescribe new drugs that have been safety tested but not necessarily efficacy tested could also be a good idea. It's very similar. The importance and vitality of off-label prescribing also reminds us that there's a voluntary approval system which operates outside of the FDA apparatus. Okay? So physicians have access, actually, to quite a bit of information on off-label prescriptions, on off-label uses, okay? From the USP Pharmacopoeia, from AMA's medical letter, okay? From the peer-reviewed scientific literature, from conferences, and so forth, from colleagues, and so forth. So there's quite a bit of information about the value of drugs, which comes outside of the FDA process. And that's important to remember when thinking about, should we allow physicians to prescribe new drugs, which have been through some trials, let's say, okay, but not through the entire gamut of FDA trials. Well, we asked physicians about this as well. Okay. What about making efficacy certification optional? Okay. So what would be your position on our proposal to change FDA law so that physicians could prescribe a new drug once the current FDA safety requirements had been met? And under this system, manufacturers and researchers could continue with efficacy certification from the FDA or perhaps from some other institution. We might talk about in the question period what that institution might be. But physicians would not be prevented from prescribing drugs that did not have efficacy certification. In other words, what would be your position on our proposal to make the FDA efficacy standards an optional form of certification rather than a requirement? And most of them said no. Okay? Nevertheless, 27%, which I think is rather remarkable, 27% of physicians were ready to sign on to what is, I think, at the present time, a rather radical proposal. So essentially, we asked them, what about going back to the pre-62 system, okay, of safety only? Okay? And at the current time, without even having much discussions, 27% were in favor. Most opposed, to be sure. Okay? But I think that suggests that this is an idea, which as radical as it may sound, okay, which would involve considerable scaling back of the FDA, okay, that this idea is at least worth some careful thought. Okay. Let me talk about some other reforms, both that have occurred and potential reforms. I've already mentioned reciprocity, okay? Allowing if a country on a list of approved countries, let's say, approves of drugs that ought to be approved in the United States. So I've talked a little bit about that. I've talked about safety only. I want to talk about the Prescription Drug User Fee Act. This, in my opinion, is the most important reform that has occurred in FDA law, in well over 50 years. It's an extremely important act, an extremely good, useful act. I'm going to talk about that. PDUFA. PDUFA is what it's called. Okay? I'm then going to talk a little bit about should we have a post-market surveillance agency. Okay? That's been mentioned in recent years, a post-market surveillance agency. I'm then going to talk about some of the advertising reforms which have been made in recent years, which I think point the way to another approach to the FDA. I'm not so much interested in the advertising reforms themselves, but the spirit of those reforms I think is actually useful. And then I'm going to talk about moving from a paternalism model to a consumer reports model for the FDA. Let's talk about the Prescription Drug User Fee Act. Basically, this is very simple. Okay? What was happening was that manufacturers would spend millions and millions of dollars doing clinical trials on new drugs. They would submit their NDAs to the FDA, okay, which often involve hundreds of thousands of pages. These are big, big documents, lots of information. So they would submit this information to the FDA, and nothing would happen. Nothing. It would simply sit there. Okay? Why? Well, because the FDA simply didn't have enough people to evaluate all of the incoming NDAs. So there was delay just because of lack of funds. Well, what the PDUFA did is it said, look, let's make a deal. It's clear that the cost of delay to the drug manufacturers, you're doing these millions of dollars worth of clinical trials, okay, and then you just have to wait just because there's not enough people at the FDA. That's costing these firms millions of dollars while they wait. So they set a deal. Let's make a deal. Okay? Manufacturers said, look, we'll fund the FDA. Okay? You just promise to earmark those funds to hire more people to evaluate our NDAs, the NDAs. Okay? So it's a very clever idea. It's really a win-win innovation here. Okay? The patients would get drugs sooner. The manufacturers would begin to sell their drugs sooner. And the FDA would get more people to better be able to do their job. It's been really remarkably successful. Here is the time from, here's the number of staff at the FDA and the time for approval of an NDA, not the research and development time, but the time for approval. So here is when the act was passed, okay? And what you see is that after the act, the number of staff goes up, and the time to approval goes way down, from about 30 months to almost 10. So the time to approval dropped in more than half. Okay? So it was very effective at speeding new drugs to patients without necessarily reducing at all the FDA's ability to evaluate. In fact, increasing the FDA's ability to evaluate these things. So I think PDUFA was really a very beneficial act. Now, it is controversial.